Good morning. Welcome to a critical appraisal session on behalf of Clinical Epidemiology Unit. We are returning after a break of 1 week. As we had said earlier, last week we didn't have the session in view of conflicting activities. So today we are resuming with continuation of diagnostic test accuracy studies. So we have had from the basics, we have been going on till reliability the week before last. So we have also had a critical appraisal session on systematic reviews of diagnostic test accuracy, but the focus there by Dr. Anna was on risk of bias and QADAS 2 tool. But today we'll once again be critically appraising a systematic review on diagnostic test accuracy, but today's focus will be predominantly on grade. We have had a series of grade also previously on interventional reviews, but it is slightly different in diagnostics test accuracy studies. So Dr. Vineeth will be handling that in today's session. As always, we welcome the audience to feel free to ask their questions either through the chat box or unmute yourself at the end of the session to ask your questions. Welcome to discuss. Without further delay, I'll hand over to Dr. Vineeth. Thank you for presenting today.
Good morning, everyone. Today we'll be looking at the grade approach in tests of diagnostic accuracy studies. So it should help us hopefully translate it from a clinical trial, which is a little bit easier to apply to the patient. This is a little bit more complicated to reach from the bedside, from the diagnostic test all the way to the bedside. So hopefully we'll see how we can look at those guidelines. So coming to the scenario, suppose you're a doctor in charge of a 100-bedded district hospital in a rural setting, and the government contacts you saying there's some new funding approved for the management of TB in children in your setting. And they want your recommendations on improving diagnostics to help pick up more cases for the National Tuberculosis Eradication Program. So you need to write a proposal justifying your choice, what you want to spend that money on, and with some evidence for the same. Okay, so we'll be looking at this systematic review, which was published in Cochrane this year, on expert TB, ultra-assay for TB and rifampicin resistance in children. Okay, it's a large multi-center trial with including studies from India also. I mean, not a multi-center trial, it's a systematic review which included trials from India also. So just to give you an overall picture of the study, they looked at the index test, which was ultra, okay, which is a CBNAT test for TB, for both pulmonary and extrapulmonary tuberculosis in children, the extrapulmonary being lymph node and meningitic TB. And they also looked at the rifampicin resistance. So they compared this against whatever the test study compared against. The acceptable standards they compared was a microbiological reference standard, which was culture. They also compared it against composite reference standard, which was used in some, such as a clinical diagnosis of TB, even in the absence of proof of TB. So they had all these multiple things that they were looking at. Pulmonary and extrapulmonary TB, rifampicin resistant and susceptible TB, and in all these different types of specimens. So they looked at specimens mainly including respiratory specimens. They were looking at expectorated or induced sputum, gastric and nasopharyngeal. Interestingly, for the gastric, in addition to the aspiration and Lavard specimens, they also looked at stool, because it's found that TB is still detectable in the stool, because as we know, most children, you can't get an induced sputum expectorated from them. So you could get a So are the results of the review valid? Coming to the validity of the study, did the review concentrate on a specific question? That's the thing. So in terms of population exposure, comparator outcomes, this is what we used to for a clinical trial. Now, how is the PICO statement different for a diagnostic test? So we still define the patient or the problem as a P, but the I becomes the index test, the test that we're looking at, the new test. And the comparator or the reference standard is the current gold standard test that we're looking at. And of course, the O or the target. So it becomes PIRT or PIRO based on what we're looking at. So coming to the PIRO statement of this study, we're looking at children aged 0 to 9 years. Now, this same group had published a systematic review around 3 years ago, but that time WHO had defined children as those from 0 to 14 years. So this time they used the revised WHO definition, which is 0 to 9 years of children with presumed pulmonary TB. That's the outcome of interest we are looking at. Although they looked at a lot of outcomes, for our PICO, it is presumed pulmonary tuberculosis. The index test is a low complexity, nucleic acid amplification test. What is this low complexity? That means the temperature and the exact setting in which the test is done is not so closely regulated. So the machine is a little bit easier to introduce in low cost settings. Whereas the high complexity CBNAT has very carefully controlled temperature and pressure settings, which means that it requires a lot of expertise to run that machine. The reference standard, some studies that they looked at used a microbiological reference standard, which took either a solid or liquid culture as the gold standard. Whereas others took a composite reference standard, which could either be a positive culture or it could be based on clinical features such as cough longer than 2 weeks, fever, or pneumonia that did not improve with antibiotics. So the clinician decided that the patient has TB. So it was a composite of that. And the outcome they were looking at is the diagnostic accuracy of the index test as compared to this gold standard test that we're looking at. So did they look for the right type of papers? So they included cross-sectional as well as cohort studies. Of course, RCTs are very difficult to come by in terms of diagnostic studies, and case control studies would not have been an ideal study design for this type of study. So they did look at the correct types of studies. Did they include all relevant studies? So they looked at all these bibliographic databases, Ovid, and they looked at Cochrane, they looked at Scopus and all that. Did they follow up references? They actually looked at the reference list of all these studies. They personally contacted experts. They looked at unpublished articles, including theses, such as pro-quest dissertations and all that. And they also did not limit the search terms only to English language studies. So they did a reasonably good search of all the available literature for the topic of interest. So coming to how they assess the quality of the studies that they got, they use the QUADAS tool. Now, the QUADAS tool actually has patient selection, index test, reference standard, and flow and timing in multiple domains. We'll briefly look at it, but for a detailed discussion on that, we already have done it in the previous session, and you can refer to the YouTube channel of CU to look at that. So the next question is, if the results of the review have been combined, was it reasonable to do so? So the most of the results were similar. However, due to a very few number of studies, we couldn't look at the tests of agreement between them very well. And the results of all studies were clearly displayed, and they showed a similar trend with largely overlapping confidence intervals. Sometimes they didn't really overlap. So this is just a visual representation, but they have not, they could not do any tests of heterogeneity on these studies because of the low numbers. Okay, so coming to the summary of the appraisal so far, what we've seen is there's a clear pyro statement. They included reasonably extensive searches. They use the correct study designs, and they will look at the risk of bias shortly. The negative things were that there were few studies, so overall we couldn't look at the heterogeneity, and the outcomes were not directly exactly what we're looking for. They're just comparing two tests and saying which is better. But as clinicians, our primary outcome is, if you treat the patient based on the test, will they get better or not? So there wasn't a direct outcome in that sense. Okay, so now coming to, so the first part that we've looked at is the validity of the review. Have they done a robust review to look at all the available evidence, look at each study in that, and robustly decide whether that study should be included or not? So coming to, actually they had 14 studies. This is just to recap what they did in their previous review. They had 14 studies in the previous version. They identified some 432 for 33 new records, and after screening and removing the duplicates and everything, they finally included 23 studies in the qualitative synthesis of data for all this. So coming to how they looked at this risk of bias. So this is the QUADAS 2 score. So I'm not going to the details of every single aspect. I just want to give some examples of how they looked at it. So it looks at all these domains, which is patient selection, index test reference, in two main headings, which is the risk of bias and the applicability concerns. So for example, in patient selection, how can you have a risk of bias? Okay. And so one thing is, if they looked at a different subset of patients than what we were looking at. Like, for example, they looked at, for example, look at this. So the NMIL 2022, they looked at convenience sampling. That's not really a good way of sampling patients. So in terms of patient selection, the risk of bias for that NMIL study is shown as high risk of bias. Similarly, if you look at the applicability of patient selection, suppose we are looking at it. So for our scenario, we're looking at it in a low cost setting. But suppose all these patients in that study were recruited at a tertiary care center, it may not exactly be applicable to our center. So that's how you apply the QUADAS tool on these domains to look at it. So I'm not going through all of it, but by and large, if you eyeball it, most of the studies look pretty robust. So there's minimal risk of bias overall in the plot that they looked at. So what were the overall results? Now that we've established that they did a good search, they've looked at the robustness of the study, what were the overall results of the study? So this is the overall results that they looked at. When you look at sputum versus culture, which is the gold standard, there were 11 studies on that. So when you pool that, so this is the meta-analysis part, especially for the interns. The systematic review is systematically looking at literature using the criteria that you have put. And this is the meta-analysis part, which is we're pooling that data together to see what does the combined data give us. So the total number of cases they got with 11 studies included was 2,990 children. Okay, and from that, they got a pooled sensitivity of 75.3% and a pooled specificity of 95.9%. We look a little further on what the implications of. So some studies had compared sputum and the composite outcome that we had referred to. So there were 10 studies which looked at those data, and they also looked at sputum in children living with HIV and sputum in children living without HIV compared to the gold standard and compared to the composite outcomes that they were looking at. So before we go into further interpretation of this is the 2x2 table that we're all familiar with. Now, what is on the right side there is the true positives plus divided by the true and false positives together. That's the positive predictive value. And of course, the negative predictive is the true negative divided by the sum of those two. And when you go vertically, there's the sensitivity and specificity. Can anyone tell me what is the main point to note over here between these two? Okay. The positive and the negative predictive value are very dependent on the prevalence of the disease in the population. Okay. So without knowing that prevalence, we can't further interpret the data that we've been given. So what is the prevalence? Now, this is actually incidence data. It's not exactly prevalence, but it's from the collaborative framework to address the burden of TB among children and adolescents and the NTEP. So this is the latest data I got. The notified TB cases are somewhere around 6 to 7%. There are two caveats for this. One is it still uses the old WHO definition, which is 0 to 14 years, whereas this review is looking at 0 to 9 years. The second thing is it's not exactly prevalence. They're looking at incidence. But using a rough estimate, and then the children, they have estimated that the true incidence will be somewhere around 10 to 13%. So we can reasonably say that the prevalence will be definitely more than 10% in our population based on this data. So coming back to this. Okay, we have the summary sensitivity, which we got from the review, and we looked at the summary specificity. And now we have the prevalence estimates of 1%, 5%, 10%. What will the true positive and the false positive rate be? How do we now use this to move further? How do we use this to now apply it into our setting? Okay, so we're all familiar with the grade approach. Okay, the grade approach is looking at systematic reviews and translating them into guideline development. So we had detailed sessions taken by Dr. Reba, again available on the YouTube channel, on how to use this approach. Okay. So from this approach, we then learned that using the types of studies and the body of evidence that we have, we can look at the certainty of that evidence and then come to how to rate that evidence based on some more parameters. It's not only the certainty of that evidence that matters. We look at the risk of bias, imprecision, indirectness, and all that. Now, the thing is, interestingly, for diagnostic studies, so if it was a non-diagnostic study, if it's a clinical trial, the highest would go to a randomized controlled trial. Okay, they will automatically start with a very high certainty and then you can downgrade them. But for a clinical trial, even cross-sectional or well-done cohort studies start off with a very high degree of certainty. Okay, so it's not only RCTs. In this situation, you have to assume that if it is a well-done cross-sectional or cohort study, you start with a high certainty of evidence. Then you go through all the steps to again look at whether you downgrade or upgrade. Okay, so what all information do we have? We looked at the systematic review, we pooled the data together, we've looked at the prevalence, and now we know in which situation to apply the data. And now we are applying the core grade approach. But the caveat is because it's a diagnostic study and we have cohort and well-done cross-sectional studies, we can give them a high certainty. So where will we move into how will we move further into looking at downgrading or upgrading the evidence that we have so far? Okay. So one thing is to look at how precise the results are also, to determine that also. So if you look at it, so because this grade approach has imprecision as one of the criteria for downgrading the evidence that we have. Okay. So far our evidence is sitting at a high degree of certainty because it's a well-done study. Now, risk of bias we already deemed was low. Overall, it was low in our population. Coming to the imprecision. So what do you all think as an opinion based on this summary sensitivity and specificity? What do you think? Do you think you will accept, or do you think you will downgrade for imprecision? Can we have a show of hands for the interns and the rest of the people who are watching, who are not exactly sure? That 75.3 is the point estimate. Okay. This confidence interval says that it can range anywhere between 68.9 to 80.8, 95% of the time. So it ranges somewhere between those two. So it can be as low as maybe 69% or as high as 80%, 81%. Okay, that's how far it ranges. So based on this, would you accept it, or would you say it is very imprecise? Okay. Or another way of interpreting the same information would be, for a population of 1,000 children, 100 would have pulmonary TB. That's the assumption we're going if there's a 10% prevalence. Okay. In that, based on this, 112 would be expert positive and 75 would truly have TB. The rest would be a false positive, and 888 would be expert negative, of which 863 would be true negative and 25 would be false negative. So I'll just show you the grade table. Okay, there's a grade tool. We'll incorporate this data into the tool and then we'll vote and see if our grading matches that of the authors of this systematic review. Okay, so this is the share now. Okay, so this is the gdt.gradepro. If you type it, it's a guideline development tool, GradePro. It's freely available online. We can use it. So coming to our question was TB in children, which is diagnostic. So I've pre-entered that and kept. What was the pool sensitivity? Okay, because we can't keep switching. I'll just enter the data for us. So the pooled sensitivity was 75.3. So 0.753. Okay, and it ranges from 68.9 to 80.8. Okay, and the specificity of this test, the pooled was 95.9. It ranges from 92.3 to 97.9. Okay, so we've entered the and the prevalences in our population. We're going to look at. Okay, so we've entered the prevalences. Now, so what do we think of the risk of bias from our appraisal so far? Sorry, it was 10%.
Good morning, sir. Can I ask a doubt?
Sure. Yeah. What's the question?
Sir, the prevalence, which was 10%,
Yeah.
so that wouldn't they have given a prevalence value in the article itself in that population? I'm just confused about that.
Haven't they given a prevalence value in the article?
In the overall, like a pooled prevalence, wouldn't they have given in the SR itself?
No. In the Cochrane review as such, they will be able to pull the sensitivity and the specificity, but it's more of the applicability. I mean, given that Dr. Vineeth had mentioned that the positive and negative predictive values usually vary based on prevalence. So in this guideline, this GradePro tool, what we will need to do is we can assume various scenarios. We
Okay.
can assume how this test would work in a
Okay.
setting where the prevalence is 5%. We can look at what will be the predictive values when the prevalence is 10%, 15%. So it's up to us
Okay.
to decide on what prevalence we need to choose. Suppose if it is a very high prevalent locality in Africa where you expect the prevalence to be much higher, you are free to put one as one of the options to be that high prevalence and see how your test is going to perform in that setting. So we are free to choose. Of course, as the authors of the Cochrane review, they would assume, depending on what their thought process is, where they want to apply this particular test, they would choose some prevalences. Of course, that may be applicable to most of the settings. But if we think that we will need to test it with the population where the prevalence is likely to be different, we are also free to put our own prevalences as well and see how it functions. So they have given some preset values. They have given it for certain probabilities, pretest probabilities. But just for demonstration, we are showing with some prevalences which we think is applicable based on the data that was shown by Dr. Vineeth.
Okay. Thank you, sir. Thank you.
Good morning, sir. Can I just ask a small doubt? If you could just clarify the reference source you used for the incidence, which you are somewhat using as a proxy for the prevalence from the NTP data. I just missed that slide. It went by quickly.
Yeah, that was just from this collaborative framework to address. It's basically it's WHO and NTP pool data. It's purely for just for estimate purpose. This is not the actual prevalence of TB. This is the incidence. That's a caveat that I said, and that's also from one study, just as an example to use for the tool.
Thank you, sir.
This should not be taken as the actual prevalence. So based on what we've discussed so far, what do we think the risk of bias is for the study? Not very serious. And the indirectness of the study. So there are two ways to look at it. One way of looking in the indirectness is it actually, if we're just looking at the outcome of diagnostic test versus the reference standard, it is pretty direct. But if we're looking at it in terms of what is the patient outcome, then it is indirect. So if you come to our PICO scenario, we are looking at it only in terms of comparison the test outcomes. So for our PICO scenario, I would put it as not serious. Okay. However, if you're a clinician and you're practicing and you're looking at it in the context of one patient, it is indirect. So I would put it as not serious. Yes. Done in a tertiary care center. Yeah. The question was, isn't it also indirectness in terms of the setting? If all the tests were done in a tertiary care setting and you're trying to apply it in a primary care setting. Yes, that is definitely a criteria for indirectness. This study did look at predominantly done in a low cost setting. So that's exactly what we're looking at. Okay, the question was, in terms of the reference standard, does that also contribute to the indirectness? Because the gold standard is not, we'll have to take the best available gold standard that we have as, because that way we can't derive any comparison. So.
Yeah, I mean, indirectness is in both ways. One is if there is any indirectness in terms of population studied, as Dr. Anna mentioned, or in terms of the tests. Suppose if the test characteristics are also different from what we are using than what has been used in the previous studies, that also will amount to it. Even in terms of reference standard, suppose the reference standard that we use in our setting is going to be different from what has been used in the studies. So any of the components of the PICO or the PRT will account for indirectness. The second aspect, which is different from interventional reviews, is what Dr. Vineeth was mentioning in terms of direct applicability to patients. So that is also amounting to an indirectness, especially in diagnostic test accuracy studies.
So overall, considering that we are again looking at the performance of two diagnostic tests, we would say it's probably not serious. And our gold standard would also be either the microbiological reference standard or the composite. So we would put, indirectness is not serious. Now, inconsistency between the studies. I don't know if you remember the previous forest plot that we showed. There were some studies without overlapping confidence intervals and they were shifting. So we would probably downgrade for inconsistency because some of the studies, the confidence intervals are not overlapping. Okay, imprecision. So by and large, most of the studies, the confidence intervals are overlapping. So we would probably not downgrade for imprecision. Now, the thing to note, the width of the confidence interval, I agree, because the pooled estimate and so there's no pooled. So yeah, pooled, it's imprecision is the width of the confidence interval of the pooled estimate. So because we looked at 70 to 80 roughly. So it's 0.69 to 0.81. It's about 10%. So again, we can have a show of hands. How many feel that is wide enough to downgrade for imprecision?
We have separately for sensitivity and specificity.
Yes. Yeah, we'll have to do it separately for sensitivity and specificity. It's yes, sir. It's this 10%. So okay, we'll have a show of hands. I think the below.
Oh, I'll do that.
So how many for downgrading for imprecision, for sensitivity? 2, 3, 4. Okay, how many for downgrading for, I mean, not downgrading, that's the rest. I think the rest, okay, there are some abstainees also, but I will contribute to that last vote and I will not downgrade for imprecision. And the other considerations, that depends on study to study. By and large, this was overall well done. Now coming to the specificity. Now, risk of bias for the specificity, again, we looked at it. Most of the studies are robustly done, so we'll say not serious. Indirectness, again, we looked at it. For our outcome, it is probably not serious. Now coming to inconsistency, we looked at the forest plot again. These are a little bit more consistent compared to the previous forest plot, so we would not downgrade. And now we'll take a vote for imprecision. For specificity, between 92 to 98. Anyone wants to say that it's imprecise? No. So we will not downgrade for imprecision. Okay. Yes. Study this. Okay. So based on this, we have come to the conclusion that for sensitivity, it's the evidence, the certainty of evidence that we have is moderate, and for specificity, it is high. Okay. Shall we now go back to the thing and see whether ours matches the? Okay. Sure. So this is what the authors concluded. Okay. So they also came to the same conclusion. So this is how we actually move from just looking at just the beginning of this. So we looked at the certainty, then we looked at the downgrading, upgrading, and then finally come to the grade. So we do concur with the authors of the systematic review that this is how we also would have graded it. Okay. So that comes to the last part of our review. We now look at, will the results help locally? Okay, so can they be applied to the local population? We also have a high TB prevalence, much like the studies, and there were Indian studies also included, which makes the applicability good for our situation. For all the important outcomes considered. Now, some of the outcomes were that the problem with diagnostic studies comparing two tests is when you don't have a good gold standard, like in terms of TB, everything that we're doing is finally indirect, because when we look at the final patient outcome, we need to follow them up, look at how many of them were actually developed TB, or if they were not treated for TB, how many of them actually went on to worsen. And so I would have liked to look at that follow-up. Strictly for our scenario, no, but would have liked to look at the follow-up overall and direct outcomes in terms of treatment. So Are the benefits worth the harms and costs? So I was looking at some of the costs of the, to do the culture in the MJIT culture medium, the cost to the government, which is again very just an eyeballing statistic, I'm not quoting anything on that, is around 3,000 rupees for the test. And for the CBNAT is comparable, it's around 2,200. And looking at all the evidence that we have so far, it is reasonably specific, the test. Okay, so what did we finally conclude? That specificity helps us to rule in the disease. Okay, so if you're looking to rule in the disease, you can use CBNAT. But if you're looking to rule out a disease, this may not be the best test overall. So coming to our scenario, can we also have a show of hands? How many would like to recommend replacing Expert Ultra instead of culture medium in at least the peripheral centers or in a 100-bedded district hospital in your DRP programs as an alternative? Based on the results of this review. Okay, so that is overall how we actually translate the evidence that we have all the way from bench to the bedside to look at it and see how we can apply. Although with the caveat that there is indirectness because this is just comparing two tests. It's not directly looking at patient outcomes. So as an individual clinician, this may not be the best evidence that we have for what we are looking at for one patient, but to look at an overall from a policy framing view and in terms of looking at it, this we can conclude that. These are my references, and I'd like to acknowledge Tambusa and Vignesh sir for all their value.